Thank you, Christoph, and thank you first of all to you, Augusto, and all the organizers of this conference for inviting me to do this. I'm humbled and honored to be given the opportunity to talk about this, and I will be talking a little bit about some general reflections on the response to the COVID-19 pandemic and some early results from the COV-PAL study. There are also some posters and oral presentations from our team that relate to this as well. I hope, just to do a sound test, that you can all hear me okay. Good. So if we could move to the next slide, please. I'm going to cover briefly the timeline of the pandemic, the initial response, and then some reflections on what we've learned so far across these broad areas, and some reflections on what next. And in case the internet goes down, my headline message really is about the need for better integration across public and charitable sector, also between clinical and research, and some possible reflections on new ways of working. If we can move to the next slide, please. So in the course of 93 days, COVID-19 moved from a mystery to a pandemic, being announced as a pandemic on March the 11th. If we could go to the next slide, please. And the initial response was fighting the disease and eventually, because it spread so quickly, lockdown. If we move to the next slide, please. So what was the role for palliative care in all of this? Well, Luca's going to talk more about that, but my own experience was through the Better Be European project, we had collaborations with Italy, and that made us think. So one of the things that we were concerned about was the growth of the pandemic, and Massimo Costantini, Carlo Porozelli, and ourselves in London were involved in a rapid telephone survey of hospices. And at the same time, a group in Switzerland and the UK were talking about the need for emergency palliative care because of the terrible losses being suffered during this growing pandemic. Next slide. But was palliative care in the international and national guidance? Well, honestly, it wasn't. The World Health Organizations and many governments produced multiple reports on prevention, intensive care, maternity, how to maintain services. People built hospitals, they built intensive care units in many of our places. There was even published in as late as July 2020 an 11-point plan for long-term care by the WHO, all of which had nothing on palliative care. So the action was left to the palliative care community. Next slide, please. In South London, we were about 3 weeks behind Italy at the forefront of the wave of the attack in the UK. And I'd like you to hear the audio by my nurse colleague, Chris Bridges, while you look at the slide.
Have you ever fallen asleep on a wintry afternoon and woken up in darkness, unsure if it's morning or midnight? That's my life currently, discombobulated and perplexing. I have an unusual job. I'm a specialist palliative care nurse, seeing patients in hospital who have life-limiting illnesses like cancer, heart failure or dementia, and assessing their needs, talking through how they're feeling, advising staff how to manage their symptoms and liaising with their relatives. Some of them are imminently dying, but by no means all of them. Many are having active treatments like chemotherapy to manage their conditions and will live for weeks, months and even years. Overnight my role has changed, but it's also the same. I'm now spending most of my time with people who have COVID-19 and are dying with this. The familiar wards are no more. Neurology is a COVID-19 ward, haematology, orthopaedics and more are all the same. Instead of long conversations by the bedside and direct discussions with their visitors, I'm muffled by mask and visor, leaning over the beds of people who are mostly semi-conscious. Instead of exploring their pain or nausea, their aspirations and concerns, My main worry is now alleviating breathlessness and agitation, with sedatives and opioids being the primary tools of choice. They're anonymous strangers in borrowed nightwear, often with no belongings other than the clothes they were wearing when they were loaded into an ambulance. They have no one coming in unless they're in their last days of life, when they're allowed one mass visitor. I don't quite know what to do. Conversely, this is familiar. The people are mostly the same people we would meet, people with end-stage illnesses who would not survive the trauma of ventilation on ITU. Decades of nursing have left me undaunted, and I can do this. I'm used to death, and I know how to manage the process, how to soothe and minimise suffering, even with new parameters and different ways of working. There are flashes of light that I carry with me. A speech therapist drafted into unfamiliar territory, caring directly for dying people with impressive competence and compassion. An elderly woman with advanced cancer who unexpectedly survived and went home relatively well again. I dislike the phrase "the new normal." I refuse to accept this. This is the new temporary. Soon I'll know the exact time of day again.
If we could move to the next slide, please. There was a real risk in South London that the palliative care service staff would be deployed to intensive care and removed from palliative care. And in response to that, we did a rapid review on the role of palliative and hospice care during pandemics, led by one of our PhD fellows, Simon Etkine. And this we analysed, showing the importance, using a framework developed by a Canadian team, looking at the systems, staff, space and stuff that you would require in a pandemic. And I hope very much that that changed both the views nationally and internationally, but also they changed the views in our local hospital. Next slide, please. There were some key messages from that study. Importantly, there was very little data from Europe, only one study, which was the Costantini study that I've already quoted, and one simulation in the USA. And most findings were based, understandably, on SARS or MERS responses and from the regions where that had been affected. But there was evidence that hospice and palliative care could have an essential role during pandemics by responding rapidly and flexible, by developing protocols, helping with triage. There seemed to be a pattern of shifting resources to the community, the importance of using technology, and also the importance of data systems. Next slide, please. So at King's, we did a rapid audit of 100 patients that were cared for us in early March to try and understand some of the symptoms that were there. One of the key features, as Chris Bridges' audio shows you, is that breathlessness, agitation, drowsiness, and delirium are key symptoms that are present. And the amount of time that you have in care with patients is short, and most people that we were caring for were elderly. Next slide, please. We found that actually from clinical experience here, and we do need better research data on this, but we found from clinical experience that actually fairly low dose medication in continuous subcutaneous infusion with morphine and midazolam especially were reasonably effective in managing these symptoms. Next slide, please. We turned this into rapid guidance, working collaboratively with the European Respiratory Society and others, and they translated it into 30 different languages. And one of the things that we learned quite early on was the need for a parallel management approach, so that you would have optimum symptom management and support for people who had severe disease and symptoms but might be likely to survive but were suffering very difficult symptoms, and also those who were deteriorated and dying, where more end-of-life care was also needed. And the symptom relief focused on respiratory and psychological distress and the different types of interventions. And you're very welcome to download any of these, and they were co-designed with patients and families, which for us was a major plus, doing it very quickly. Next slide, please. But we shouldn't forget our existing patients, and many people with severe symptoms and chronic diseases such as respiratory diseases and cancers and heart failure were actually struggling to be at home reluctant to go to hospitals because of fear of travel, fear of getting infected. So we improved the resources to help people self-manage symptoms at home, and led by some of my colleagues at the Institute, we rapidly turned some of the best evidence for home management for breathlessness so that people with existing diseases could follow this and presumably help manage things at home. And I'm delighted that this spread very quickly to be used. Next slide, please. We were also concerned to bring in the patient and family voice, and supported by the UK National Institutes of Health Research, we'd already started an online forum for patient involvement. And through this, we were able to rapidly collect information about people's concerns. And patients and families had worries in 4 main areas. They were missing the existing professional support, delays, disruptions. They were risking and worrying about reduced quality of care and great fears about rationing. There were great strains on informal carers who had the dual challenge of, when people were in hospital, not being able to visit and becoming visitors, not carers, but also much more home care. And then the challenges of loss, grief, and bereavement. Next slide, please. And on the back of that, we launched the CovPal study, which Christoph mentioned, which started with no real funding, but successfully managed to win funding from both the UKRI, and we were able to redivert through the chance of the UK government money from the NIHR to this. Next slide, please. Thank you. So we did the study because of the lack of palliative care in the guidance, and that services were hugely affected. And we surveyed clinical leads of palliative care services, and we received responses from 458 different clinical leads across the countries that you can see here. We'll be publishing soon, and we have more on our website, which is, the link is there. But we had a good mix across different settings, and also a mix of charitable and public management. Next slide, please. So just to keep moving on with what we found. 81% of responding services had cared for people with suspected or confirmed COVID. And importantly, we should recognise that staff often had had suspected or confirmed COVID. People developed guidelines and education materials. They helped in various different activities. There was a reduction in inpatient palliative care activity in freestanding units, and an increase for home and hospital teams. There were challenges about continuing to use volunteers, and particularly for the charitable sector, there were major financial concerns. Next slide, please. Staff were concerned and distressed at times. You can read some of the quotes there on that. And we saw that patients were dying from or suffering with COVID in 3 main groups. There were people who had underlying conditions and or multimorbidity, but previously not known to palliative care. There were people already known to palliative care. And then there were previously healthy people who also were getting COVID. And these 3 groups require slightly different approaches. Next slide, please. We also found that palliative care, like many other services, suffered from major shortages. And here, those shortages are shown for PPE, personal protective equipment, staff, medicines and other equipment by the type of management, world region, and the different settings. Bear in mind there's some overlap between the settings. And what you can see is that the charitable sector in particular was suffering from personal protective equipment shortages, that staff shortages were more universal by setting and by charity and public sector, but that actually the UK had particular challenges with shortages of staff. Next slide, please. And what services did was amazing. I cannot tell you all of the things, but I highlight a few here, and there is more on some of the posters that we have at this conference. So they dedicated people to try and source personal protective equipment. They switched in creative ways the drugs because of medicine shortages. They changed how they worked because of staff shortages. There was a lot of anxiety about this also, if we could go to the next slide, please. Because people sometimes felt that there was a moral harm making decisions about not being able to visit people. And one of the key conclusions from the COV-PAL study is that services were often overwhelmed, but often also ignored during the response. And because of some of the challenges that we see and the fact that they were ignored in many countries by the central response, we need to think about ways to have better integration. And we need to reflect on how the challenges were different for the charitable and public sector, and also be prepared as COVID continues about how we might shift our resources or use our inpatient and community and hospital services. So next slide, please. So I want to end really with some final thoughts and reflections. We have now had over 1 million deaths confirmed as due to COVID-19, whether you use the WHO or the Worldometer data. Next slide, please. I think the excess deaths is probably a more important figure than the number of deaths due to COVID, because of the difficulties of whether and how countries have or have not reported COVID deaths. And this shows it for a number of selected countries. I apologize if your country is not included in this selection. It's difficult to do. And not all countries have information on COVID deaths, but you can see how the wave occurred there. You can see how it's continuing high in some countries. I think that's the United States with the excess deaths up there. You can see the peak of the wave very high for Spain, was the country that hit 140% on excess deaths in March. The UK is the next highest along, and I think Italy is the next one below that. But it's not just deaths, and we also need, and I think we should be reflecting going forward about some of the long-term effects of COVID-19 and potentially also the rehabilitation needs that some of our patients will face. So to come to my end slide and the take-home messages, please. I think I have to admit that the more I look at this story, the more I feel that centrally in governments, in the WHO, palliative and hospice care was often ignored in the pandemic response. Now, there were some brilliant articles, including 2 editorials in The Lancet, which challenged this and brought attention to palliative care. But I would also say that from the palliative and hospice care community, there are many leaders in this story, and I am humbled by the way in which people responded. I think we have learned an awful lot so far. We've learned about symptom management and end-of-life care in this new disease, which will help us going forward. We need to reflect on how the changing care settings might influence how we develop in the future. We've learned some of the challenges of delivering holistic care in this situation. And we've learned some of the challenges on advanced care planning and communication, and in particular, some of the concerns that arose from the public and patient involvement about rationing. And we've looked at that more in the COV-PAL data, and some of the COV-PAL team are publishing that at the moment. We've learned the importance of education, which is vital, particularly when our services are overwhelmed. And adapting from teams in Italy, we developed in London a brief 15-minute sort of education. We've also developed a new way of doing research, critical to learn about this new disease, and I'm impressed at how palliative care embraced research in a new way, but also the importance of research in making palliative care visible. And we need better data on outcomes, and in the COV-PAL study, our next phase is collecting some of this. We also must remember that people still need palliative care for the old reasons, and actually that's the main reason why people still die. And we need to reflect on some of the potential long-term effects of COVID, maybe improving our symptom management and the rehabilitation side for our patients. So what next? Well, new ways of working, I think, our flexibility, our integration and collaboration. And I'd like to say thank you to the many colleagues who were in the front line doing research, to the patients and families who engaged with us over this, The journal editors are often forgotten and deserve a special round of applause for quickly stepping up, the charities, the EAPC in particular, funders, and many more. So thank you, and I hope we get some discussion.